Good afternoon, everyone. Welcome to the endocrinology grand rounds for today. So we are very happy today to have our most recent faculty hire to present to us. Dr. Rebecca Jeun joined us in October of 2023. She is currently assistant professor in the Division of Endocrinology, Department of Medicine. She obtained her undergraduate degree from Rice University with a BS in biochemistry and cell biology. She then went to medical school at Baylor College of Medicine. After medical school, she went to do residency at Johns Hopkins with special interest in patient safety and quality improvement pathway. Subsequently, she came back to Baylor, finished her endocrinology fellowship, and after that, she was on faculty at Indiana University School of Medicine before she moved here. So we were very happy to have her here to get our endocrinology department a broader range of faculty with excellent training and experience. She has been active in the academic field, and she has 8 publications to her credit. And today she will be presenting to us on the management of pheochromocytoma and paraganglioma.
Thank you for the introduction, and it's a pleasure to talk with you all today. I don't project my voice very well, so let me know if you can't hear me, but we'll do our best. So, like Dr. McGundam said, I'm going to be talking about management strategies in pheochromocytoma and paraganglioma. Hopefully it will be helpful for, particularly the fellows in sort of some of the practical aspects of management, and then some of kind of the emerging therapies that are becoming available. So I don't have any disclosures. And this is our kind of agenda for today. So I'll go over just kind of a general background introduction to these tumors, and then kind of split up the talk to basically parasympathetic and then sympathetic lesions, go over the touch briefly on screening and diagnosis, and then kind of talk a little bit about the genetic testing that we might recommend for these patients, then talk about the some of the more practical aspects of perioperative management, and then what are our options for patients with metastatic or inoperable disease, including some of the systemic therapies that are available. So probably most of you are familiar with this, but just as kind of a background, so pheochromocytomas and paragangliomas are, histologically similar. So some of the different classifications come up in terms of sort of the location of origin and, are they catecholamine producing or not? But basically, they're not so rare for us, obviously, in the specialist clinic, but generally speaking, these are rare endocrine tumors, and they arise from the neural crest-derived chromatin cells. And so when they're intraadrenal, we call these pheochromocytomas. Some papers also call them intraadrenal sympathetic paragangliomas. And oftentimes these are secreting one or more catecholamines like epinephrine, norepinephrine, or dopamine. And occasionally these are biochemically silent. And then below the diaphragm, you can also have extraadrenal sympathetic paragangliomas that also are functionally active. And then the parasympathetic paragangliomas, which are generally in the head and neck and more clinically silent in the sense of do not produce catecholamines, but may exert mass effect. And that's where more of the symptoms arise from. And I'll first talk about parasympathetic paragangliomas. I think this is a an interesting topic in the sense that, we usually don't see a lot of these, or at least in my experience, my limited experience, haven't seen as many of these in the clinic because most of these end up being, go through the head and neck clinics because most of them are non-secreting. So maybe only like 5% will secrete catecholamines. The rest, the issues arise from basically mass effect symptoms. But essentially, so the majority of these are going to be head and neck. In terms of the parasympathetic paragangliomas, about 65 to 70%, and these represent about 0.6% of all head and neck cancers. So not common, but these are things that will come up, in the ENT clinic and that kind of thing. And so they can arise in these locations. This illustration kind of shows the different locations of the parasympathetic the ganglia that where you can get these paragangliomas. And so the most common ones that you'll see are actually in around the carotid body. So carotid body paragangliomas comprise about 60% of these, and generally will, if they're large enough, can present as a neck mass with symptoms of like cough and hoarseness or dysphagia. Um, and so the other kind of areas would be the jugular bulb paragangliomas or tympanic paragangliomas. And so these can present with things like pulsatile tinnitus and hearing loss or vertigo. So as you might expect, these will show up in the ENT clinic, not our clinic necessarily at first. And so like I said, the most common is the carotid body ones. There's kind of a broad age of onset, but for the tumors associated with the hereditary syndrome, the onset will be about 10 years earlier. The only known acquired risk factor is actually chronic hypoxia. So interestingly, they've shown clear correlation in studies of Peruvian patients that live in the Andes and at high altitudes that have higher rates of these paragangliomas. There is a small percentage that do develop metastases, and so more commonly it's regional lymph nodes, but it can also go to lung and bone. And there are some differences in terms of kind of the behavior depending on the genetic profiles, which I'll talk more about later in the talk. But to give you kind of an example, so for the jugulotympanic head and neck paragangliomas, the ones that are not associated with SDH syndrome tend to rise more in older women and have less aggressive phenotype in terms of less metastatic potential. Um, if you have patients that have metastases to regional lymph nodes, the 5-year survival rate goes down to about 75%. And then if you have distant metastases, it's a very poor prognostic feature. And so the 5-year survival rate is closer to like 11%. The rarest group of these will be arising at the around the vagal nerve, usually at the inferior ganglion. And so when these get large enough, they can kind of have the same symptoms of dysphagia, hoarseness, and vocal cord paralysis. And so the kind of general sense, even though the secretion of catecholamines is uncommon, that's something that the head and neck folks need to be aware of in terms of checking for these things and have them evaluated further for that with us. When we talk about like metastatic disease, we'll kind of talk more about sort of the treatment options because that can all be categorized together towards the end. But so in terms of the management, so largely this will be dependent on whether or not these are symptomatic or if these are functional. So if it's an isolated lesion, of course, it will be surgical resection. And generally, these have good outcomes if these are operable. Other techniques that have been proposed are things like ablative stereotactic radiation, but there's not really data to support usage of that over surgery at this point. And if you kind of look at the different areas, so carotid versus vagal, tympanic, the location matters a lot in terms of the ability to resect these. And so our surgical colleagues can probably talk a lot more about this. But basically, things like the vagal or the jugular paragangliomas are more challenging resections due to the structures nearby that are involved. So for example, for like jugular lesions, there's a high incidence of cranial nerve palsies. And so, radiation might be considered as a frontline option unless there's catecholamine excess or very large tumors, or rapidly progressive disease, in which case surgery may be considered. So these are some of the things that would be talked about, like in a multidisciplinary situation, to decide kind of what is the best kind of upfront management. And the other thing to note is that, if these patients are asymptomatic and they're not, producing any catecholamines, and there's not really a risk of metastatic disease in the sense that, they don't have any concerning, mutations, like germline mutations, then it's reasonable to consider observation in these cases. And so, usually this is done like every 6 months with cross-sectional imaging, and then can be spaced out to annually. So moving on to kind of the bulk of this discussion will be for sympathetic paragangliomas. So like I mentioned, there are the intraadrenal lesions, which we know as pheochromocytomas. And then there also are extraadrenal lesions. So the majority of these will be in the retroperitoneum. More commonly, these are intra-abdominal, and then less commonly, you can find these in the urinary bladder or intrathoracic and cervical lesions, and about a quarter of these will be functional. More commonly, these are, associated with syndromes and multicentric and metastatic. Onset tends to be in the third and fifth decades of life. And then, the classic kind of symptoms of catecholamine excess, will be seen, or sometimes if they get large enough, you can get mass effect. So, things like the urinary bladder paragangliomas, I've never personally seen, but it's a fairly interesting kind of clinical triad where patients can have paroxysmal hypertension, and then intermittent gross hematuria, and then basically micturitional attacks of like the classic, pheo type symptoms of the headache and pallor, anxiety, basically the catecholamine related symptoms. You can find these in the gallbladder at times, and then there's even spinal ones. And so those become an issue if they're invading, infiltrating into like soft tissue or bone, or can also be found from the skull base and invade into the cranial cavity. So, why are we on the lookout for these conditions? As you guys probably all know, there is a really high cardiovascular morbidity and mortality if these are left untreated. Looking at kind of all comers of patients with hypertension in the outpatient setting in a general medicine clinic, it's about less than 1% of these patients will be expected to have pheochromocytoma or sympathetic paraganglioma. That percentage goes up quite a bit in the pediatric population. And then, of course, this is part of the routine evaluation for adrenal incidentallomas, depending on kind of the imaging features, but it's thought to be about 5% of these cases. And so the interesting, part of these lesions is that, there's very high heritability. So we think about half of these cases are attributed to an inherited mutation. And so, the diagnosis we, as with most things in endocrinology, need to establish it biochemically first. And so, we'll screen with plasma-free metanephrines and urinary fractionated metanephrines. I won't go into kind of all the nuances of that. I think Dr. Kulkarni covered that for us at his fellows talk. But that's kind of the general gist of the initial evaluation, and then we move on to localizing imaging studies, and then we'll talk about over the coming slides things like genetic testing, and then the management. So the genetic testing is a pretty important piece of the evaluation. So I think there's been some debate in the past about sort of, should we offer genetic testing to all comers, or, sort of be more selective about it. I think a lot of it will depend on the institutional resources and, kind of the cost implications. But, I think in an ideal world, I think it would be reasonable to kind of offer everybody if it's within kind of the resources available, particularly because of the high heritability and sort of impact on some of the personalized medication options later, or treatment options, as we're moving towards more of a precision medicine approach for these diseases. And then so it'll impact like what other diseases you might be looking for that are comorbid, like for example, an MEN2 or SDH syndromes. And then of course, screening in asymptomatic relatives who are carriers. But to give you an example, if you find an SDHB mutation, this is really associated with a significant burden of metastatic disease. Um, and so I think if the resources are limited, I think definitely young patients should be offered genetic testing. Now, your cutoff for young, what is what is that going to be? Is it 40, 50, 60 years old, depending on who you're talking to, by institution? Family history, if there's any other features of a inherited syndrome, or this patient has multiple tumors that are suspicious for a syndrome, or extraadrenal disease would be another good indication. And so the combination of both, germline testing, and also you can do, IHC or tumor testing, should be able to identify mutations in up to like 80% of these, or identify driver mutations in a large majority of these patients, so up to 80%. I think patients that you might feel reasonable to exclude genetic testing for would be older patients with unilateral pheo that you don't have any evidence for, family history, or no concerns for an inherited syndrome, no other malignant features. But essentially, there's been over 15 pheo and paraganglioma predisposition genes that have been identified. So I'm sure a lot of you are very, familiar with a lot of these, but so these are like NF1, associated with neurofibromatosis, right, with MEN2, von Hippel-Lindau syndrome, and then all the SDH syndromes. And then the rest are some of the more rare kind of etiologies. But the SDH genes are probably the most commonly inherited predisposition genes, and then followed by the ones associated with syndromic presentations like von Hippel-Lindau and MEN2, and then neurofibromatosis type 1. So, um, uh, but essentially, kind of the thought is that the germline mutation basically inactivates a tumor suppressor gene in a lot of these. And then the tumor itself contains a somatic event, so kind of like a two-hit hypothesis, such as a large chromosomal deletion that then inactivates the wild type allele and then leads to tumor formation. So, hopefully, if you have access to, genetic counseling, this will be kind of part of, what the genetic counselors will offer for you. But essentially, if you identify the pathogenic variant, and then, the patient will, you'll engage in shared decision making with the patient about kind of cascade testing for their relatives, and that will help determine, what kind of testing they need, and kind of the risk of, which tumors and how often do they need to be screened. And so, again, this kind of points towards this more kind of precision medicine approach, where the screening paradigm for the relatives will depend on the specific inherited mutations. And there's some particular in certain situations, there's a little bit of difference in terms of like SDHD, or the SDHA. HAF1 and MAX mutations, there's a parent of origin effect on the risk. So, maternal transmission of a pathogenic variant is associated with low risk of clinical disease. So, depending on, the family tree, that will obviously impact the surveillance scheme. And then this is another thing that Dr. Kulkarni went over for us, so I won't spend too much time on this. But basically, with the advances in, genetic testing, we have a lot more information on kind of the genetic profiles of these tumors, and then kind of the genotype phenotype relationships. So the there's been kind of three clusters proposed as a way to classify these molecularly. And so cluster one is called the pseudohypoxia group. And within this, we think there are two basically subtypes, which are Krebs cycle related mutations. And so that falls, so the SEH syndromes fall into that, and then the FH mutations. And then the other subtype would be the von Hippel-Lindau. And then so the tumors in this grouping tend to be extraadrenal and noradrenergic, for the SDH mutations, oftentimes co-secrete dopamine. In the second cluster, this is the kinase signaling group. This would be things like MEN2 syndrome and neurofibromatosis type 1 fall into this category. You see more adrenal and adrenergic phenotype. And then cluster 3 is less well known, but so you can see kind of a variable presentation for that, but tends to be more adrenal. And so, that has some implications that we've seen in terms of how uh, which kind of tumors and respond to which type of imaging, basically functional imaging, for example, with the MIBG scans or the gallium dotatate scans. So, not that you guys have to, memorize or anything like that, but these kind of just give you a sense of, this is kind of going more towards, the sort of precision medicine aspect that, depending on, what the underlying genetic profile is, there may be variation in which kind of scan that you can pick up disease more easily on there. And I think the other thing to consider is, particularly if you have, more high risk features in terms of like very large tumor size or known metastatic disease or extraadrenal location or an SDHB mutation, for example, on a given patient, then then you would proceed with functional testing to look for, metastatic disease or additional tumors. So, moving on to perioperative management, I think I feel like we talked about this ad nauseum in fellowship, and kind of. So I'll try to keep this quick. But so of course everyone is familiar with the kind of the standard. So the mainstay of treatment basically is, let's say you've made the diagnosis and the patient needs to go to surgery. Let's say for a pheo, the goal is to do alpha blockade for 7 to 14 days kind of ahead of time. And that's to prevent cardiovascular complications and hemodynamic instability, with the manipulation of tumor during surgery, and kind of the catecholamine release, and then, anesthesia as well. And so essentially the paradigm is to start with alpha blockade. If you get reflex tachycardia later, then you start beta blockade. Calcium channel blockers are also a reasonable option if patients are either normotensive um, or as an adjunctive therapy if you've sort of maximized alpha and beta blockade, or if they can't tolerate alpha, higher doses of alpha blockade, but you still need more blood pressure control. There's some, mixed data because a lot of this is retrospective data. And so this is all, some, based on retrospective like case series and, expert opinion. So, some places will say, never use labetalol. Some obviously there's a case report for everything. So there's, case reports that they've used labetalol successfully to prepare patients. The thought behind like not using labetalol is that there's relatively more beta blockade. And so you worry about sort of the unopposed, alpha stimulation. In some places I've read, people use magnesium sulfate as an extra kind of addition to inhibit catecholamine release kind of around the time of surgery, but I don't have as much experience using that. And so basically, the main reason is that, it has been clearly shown that patients who are not kind of adequately blockaded and undergo surgery have high surgical morbidity and mortality. Due to the hemodynamic issues. And so even in normotensive patients, you still should consider something like a calcium channel blocker. Even, if you think or even if you have assessed that they have a low level of circulating catecholamines, because they have similar issues with perioperative hemodynamic instability. It's also recommended to get a baseline echo to look for cardiomyopathy, and obviously that would have implication in kind of your fluid management and how aggressive you can be with things like beta blockade. And so how do you assess the adequacy of your kind of preparation? So the Rosen criteria were proposed in the early 1980s. Basically, and the Endocrine Society also, obviously has some guidelines on this. But essentially, what we're looking for is to have good blood pressure control. We often target mild orthostatic hypotension, but try to avoid very frank hypotension, and have heart rate control. and then hopefully no, issues with arrhythmia and, ST segment changes on EKG. So, what are the agents that we can use? So, I think a lot of the things that you'll read basically mention phenoxybenzamine. Personally, I've never seen it, anyone use it because I think of cost and also the, because of its very long, length of action. That's kind of a double-edged sword in the sense that it's very effective, but post-operatively the effect can still linger. So you have issues with post-operative hypotension, and sometimes patients need vasopressors. And then there's obviously like a cost issue for that. So some of the more experienced endocrinologists can let us know kind of what their paradigms are. But usually I've seen basically the selective alpha blockers use like prazosin, doxazosin, or terazosin. And these are kind of the, sort of standard dosages that you'll start and then titrate up towards, the target blood pressure and heart rate readings. So when I was talking about a little bit of the cost, so when I looked up, phenoxybenzamine on GoodRx, right? So if they have this kind of interesting tool, which I didn't know was there before, but basically there's not the insurance coverage is very hit or miss, and then the copay range is also pretty widely variable. So if you compare that to doxazosin, pretty much everyone has this covered, and the copay is minimal. So I think since the selective alpha blockers work well and are cheap and easy to get, that's kind of what I have used in practice. And then coming to tyrosine, so I understand that other institutions like Mayo use this a lot more commonly. Again, this is another drug that I don't have as much familiarity with, but essentially, this drug basically decreases catecholamine biosynthesis significantly. So it's a tyrosine hydroxylase inhibitor, and so it sort of acts in blocking the conversion of tyrosine to DOPA. It's been proposed to add this on if patients are on maximal doses of alpha and beta blockade, or they're intolerant to alpha blockade. It sounds like Mayo does use this as like kind of pre-treatment for patients with like inoperable disease that they're going for like radionuclide therapy or radiation or things like that, where they're worried about the catecholamine release. But this needs to be started at least 2 to 3 days prior to surgery. Main side effects seem to be like drowsiness, fatigue, and then because of the decline in dopamine levels, you can get some extrapyramidal side effects. And then some of the other strategies, that have been written about are, admitting patients a couple days ahead of time and using IV phenoxybenzamine. The other thing to consider, that's kind of standard recommendation is, after a couple days on alpha blockade, starting high salt diet and fluid intake to kind of bump up the vascular volume and prevent orthostatic hypotension. One of the endocrine surgeons at Baylor, I think, would often admit patients like, 1 or 2 days ahead of time, and so that they could aggressively sort of continue to up titrate alpha blockade and beta blockade, but also give IV saline during that time to try to prevent hemodynamic instability. So a lot of these strategies, there's not like high quality evidence for. It's a lot of expert opinion, that kind of thing. But these are some of the strategies that have been used. And then the next couple of slides are going to be some of the other issues that come up around kind of after diagnosis that you may see. So, hyperglycemia from the catecholamine excess. And so the proposed mechanism is basically inhibition of insulin secretion and increased insulin resistance. And so generally this will resolve after, resection of the kind of offending tumor. But you do have to be mindful of, once that source is removed, there can be, with the sudden drop in circulating catecholamines, rebound hyperinsulinemia and then hypoglycemia. And then if they're on beta blocker still, then that can mask the symptoms of hypoglycemia. But otherwise, kind of the standard things that we'll do for management of diabetes perioperatively or hyperglycemia perioperatively. And then another issue that I think is maybe a little bit kind of underreported, recognized, maybe would be like the GI side effects. So constipation can be an issue in these patients due to catecholamine release, and also some, if they're getting, various procedures and opiates and those kind of things. And so the abdominal discomfort, pain leads to further release of catecholamines, and then you get in this kind of like vicious cycle. So the recommendations, are kind of starting, kind of the standard things in terms of like lifestyle measures. So increase fluid and fiber intake, prune juice. There's some data for that. And then, if severe, then start moving into pharmacotherapy, but basically trying to avoid anything that will, provoke abdominal cramping and more catecholamine release. So things like senna, and bisacodyl to try to avoid those things. And metyrosine may also help in the situation because of the actual lowering of the catecholamine biosynthesis. So in terms of metastatic disease, there's some other things to consider besides just sort of like getting the patient through to surgery would be, for things like bone mets. So bone involvement can be, fairly common, with some of these diseases. And so you get, sort of the things that you would expect, like bone pain and pathologic fractures, things, issues with like compression of different neurologic structures. And so this is often, multidisciplinary discussion with orthopedic surgery or neurosurgery, or that kind of thing, or radiation oncology, depending on sort of what specifically is going on and how best to address it. But, these patients may need surgical intervention. If it's very diffuse disease, that's kind of where you might be thinking about systemic therapy. And then kind of keeping in mind that medications that are commonly prescribed to help, the symptoms or, decrease inflammation, like steroids and, opiates for pain, can worsen the catecholamine release. The anti-resortives may also have a role in prevention of, pathologic fracture and kind of, skeletal events with dosing schemes that are sort of more expected, that you see more commonly with in terms of like the oncologic side of things. Obviously, these are obviously not the dosing schemes that we usually use for osteoporosis, but reclass or Prolia, or I guess actually Xgeva, that is dosing would be what you can use. So in terms of surgical management, we'll just kind of touch on briefly. So of course, if it's a single, localized lesion, that's something that would be, you would plan for resection. Generally for, pheochromocytomas, the recommended approach is laparoscopic, but ultimately the type of approach will be obviously up to your surgeon. And then open is used in the cases of very large tumors or difficult access or a failed laparoscopic approach. One area that, having the genetic testing prior may be helpful would be, for example, if you have syndromes like MEN2 or von Hippel-Lindau, where you might expect, involvement of the other adrenal gland at some point, you would try to perhaps opt for a adrenal cortical sparing approach. But that's something to, obviously be discussed with the surgery team. And then moving towards, metastatic disease or unresectable disease, it's can be a quite difficult subject, and that's where our oncology colleagues can help us a lot. But I'll just kind of touch on the different options that are available, but kind of the paradigm to be thinking about, and I'll actually come back to the slide in a second, but. Um, essentially, when you have metastatic disease, right? So you want to evaluate, how symptomatic they are, what is the degree of catecholamine release, where is the tumor, is there metastatic disease, or is it widely, spread? And so there are kind of different approaches, and this is oftentimes discussed in a multidisciplinary setting, because there's a couple different, there's several different modalities that are offered. The one that's FDA approved is called a Zedra, and so this is a high specific activity I-131 radio-labeled. So this is a radionuclide targeted therapy. And so this was approved in 2018, but when I was preparing for this talk, I realized that they are taking it off the market because of lack of demand. So now we won't have access to this after April. But in the past, when it was being used, there was a dosimetry assessment initially, and then the standard treatment regimen was 2 doses, basically given at least 90 days apart. And these patients must be treated with SSKI or Lugol's to have thyroid blockade at least 24 hours before and up to 10 days after each dose. And the most common side effects would that have been noted are myelosuppression, nausea, vomiting, and fatigue. But a lot of these patients have received, multiple lines of therapy, so that may also have been contributing. And so the data to support Azedro came from a Penn study, I think in 2018. And so basically there was a, still minority percentage, but, did see some improvement in reduction in antihypertensives on this treatment, both after 1 and 2 therapeutic doses. And so no patients achieved complete response, but a proportion did achieve partial response, and majority of patients achieved stable disease. So that's kind of established, that's the kind of main therapeutic goal with using this kind of therapy, is mainly disease stabilization and symptom control, not curative intent. And so another radionuclide that has been used is something called Lutathera. And so this was approved in 2018 for well-differentiated or inoperable enteropancreatic neuroendocrine tumors, but has been used off-label for Pheos and metastatic Pheos and paragangliomas. So kind of similar, a lot of these patients will achieve partial response or stable disease. There's currently a trial running at the NIH looking at patients with SDH mutations versus sporadic disease, and whether not there's a difference in response there. And then there are some investigational agents. So there's some interest in, combination therapy or alpha emitter therapy. These agents have shorter range and high linear energy transfer than the older agents. And so the thought is that these will basically be more targeted with less cytotoxicity to the surrounding tissue. But again, this is offered on trial only or compassionate use protocols. And so there are some more things that are under investigation. And then coming back around to the idea of kind of a precision medicine approach. So this is going back to the ideas of the the 3 clusters that we had talked about earlier, and the different pathways that are involved in the aberrant signaling that lead to tumor development. And so this graphic, it's a little bit busy, but it just kind of shows you some of the potential, targets for the different oncologic agents, and sort of the rationale. So things that, have been, under study would be things like using, mTOR inhibitors or the TKIs or RET inhibitors. And then there's interest in, potentially immunotherapy. And so the kind of I think the take home is that, the genetic profiling, I think, will in the future be, a lot more, as a lot of things in oncology are moving towards a more, personalized decision-making approach. And hopefully we'll see, more data come out about some of these agents going forward. And then in terms of long-term follow-up, kind of on that same theme, we're starting to target, the kind of the pace of the follow-up and types of screening, dependent on the particular genetic profile. So this is kind of a proposed schema that, if the patient with a known, pheochromocytoma or paraganglioma, doesn't have any genetic variant and no, risk factors for metastatic disease, would recommend follow-up for up to 10 years. And then for patients with a known germline pathogenic variant, actually would be recommended for lifelong follow-up. And then if you have a germline variant of uncertain significance or, significant risk factors like family history or multiple tumors, that kind of thing, continue follow-up for 10 years, but reassess after 10 to see if that should be continued. And so in this group, basically younger patients, patients with extraadrenal paragangliomas, and could consider for patients with very large tumors, over 5 centimeters, or one of the noradrenergic or dopaminergic phenotypes. And this is just to kind of, again, show you, the thought is to kind of tailor it more depending on the genetic profile. So for like the cluster 1 patients, there will be difference in terms of the timing. As we know that the, SDH B and A mutations are, associated with more metastatic disease and more, poor prognostic factors. So the follow-up in terms of both biochemically and with imaging is more frequent, at 6 to 12 months instead of for like the SDHC mutations or SDHD, 12 months for biochemistries, or every 2 to 3 years for the imaging. And then, of course, if you have a known syndrome, like MEN2, you'd be looking for the associated, disorders like primary hyperparathyroidism, medullary thyroid cancer. And there are some other, proposed screening paradigms for the mutation carriers, but who don't have clinically apparent disease yet. And so this is, the cluster 2. So these are like the RET mutation patients. And then the cluster 3, less kind of known about, but thought to be more similar to the cluster 1. So generally kind of follow that screening paradigm. So with that, I will wrap up here and take any questions.
Hi, Rebecca.
Oh, hi.
This is Satya. Sorry I couldn't be there. That was a great
That's okay.
overview. So my question was related to the preoperative prep, and that's always something, we sort of pay a lot of attention, but always have a lot of questions. So some of those patients also have heart failure, like cardiomyopathy related to long-standing hypertension. And I know alpha blockers, at least as of what I know, is relatively contraindicated. So in those patients, are we able to do with the phenoxybenzamine, or is there any other recommendations there?
Oops, sorry. So, yeah, so that's a great question because, and I have to admit, I didn't actually specifically look into the heart failure, the patient population, but I would expect you would have the same concerns. I think the question would be, so I think you would have to differentiate, is it HFpEF or HFrEF? And then, work with the cardiologist in terms of, what you think they might tolerate and if they're hypertensive. Of course, if you have some concerns about like volume overload and, or like right heart failure, beta blockade becomes an issue. But that's something that, yeah, that's a good question. I have to look into more, is specifically the heart failure population. That's a very difficult thing to handle because, obviously that you can't give them lots of volume either, once you have been doing the alpha and beta blockade, if you've been doing that. So my guess would be calcium channel blockers might be the way to go, but that's something I would probably have to work with the cardiologist on.
Sure, yeah. Yeah. Thank you.
I don't think so. Yeah, I think that's it. Oh, wait. Oh, no, never mind. Sorry, there are a couple. Let's see. Okay. Sorry, there are a couple. First question is, are there any blood parameters like elevated chromogranin level that can give an early indication? Is there staging done after laparoscopic surgery? So yeah, so I think so the chromogranin A is an interesting question. So it's not like a routine like biomarker that we'll recommend checking, but I think if you have for example, like a head and neck paraganglioma that is not secreting, epinephrine or norepinephrine, what markers can you use? Or if you think you have a non-secreting phenotype, then the chromogranin A may be useful in that situation. There's obviously a lot of caveats in terms of, things like proton pump inhibitors can raise those levels and give you false positives and that kind of thing. But yeah, for like the head and neck paragangliomas, they're thought to be maybe more dopamine secreting. And so it's proposed to actually try to track a metabolite called methoxytyrosine, I think. I have to double check on that one, but that's not like a routine one that we'll do. And then staging after laparoscopic surgery. So I think usually if you have a concern about metastatic disease or like multiple tumors, that should all the imaging should be done before surgery. So then you can decide on the surgical plan, even with laparoscopic. And then for the checkpoint inhibitors, I believe these are all still on trial, but they're not FDA approved for this particular indication yet. So I think the main systemic therapy that's been approved is the Azedra, but now that will be coming off the market. So the rest of these will be off label. So these patients will be on like clinical trials at the cancer centers and that kind of thing. Okay, I think that's it here. That's a good question. I guess if you have a clinically silent, if everything else is normal, yeah. I don't know that's a good prognostic factor, but you would have to be reliant on basically radiologic follow-up essentially. And so I think it still holds true that you would still need to do surveillance, but you can't really use the biomarkers to help guide you. It would all be radiographic.
Rebecca, I have one more question.
Yep.
Early on, you had mentioned with the head and neck, pulsatile tinnitus, and I wasn't aware of that as a symptom related to the head and neck PGL. So can you just elaborate on that a little bit if you?
Yeah, so and I probably will be speaking out of turn, so my husband may have something to say about that. But
I know.
but yeah, so I think basically if there's so the jugular bulbar ones, the tympanic paragangliomas, because of the location in association with like cranial nerve 8, basically you can have inner ear symptoms. Besides that, I don't know a lot more, so I can, maybe that's something we can have my husband do.
Sure. Yeah, definitely. Thank you.
Thanks. All righty. Thank you, everyone.